At the outset, I would like to thank APS Kochi for having given me this opportunity. So antiphospholipid syndrome is not very common, and this just a little atypical presentations of APS is what I would like to highlight in these three cases. The treatment remains pretty much the same, but the presentation was a little atypical. So let's start off. Okay, Aparna.
Good evening, everyone. First of all, I would like to thank my consultants for giving me this opportunity to present here. Myself, Dr. Aparna, I am here to present many phases of Hughes syndrome, 3 interesting cases of APS. First case, it's a 56-year-old female. She is a known case of antiphospholipid syndrome with history of pulmonary thromboembolism in 2013. She was on warfarin since then. She is a known case of systemic hypertension, presented with complaints of gradually progressive headache since 1 week, generalized weakness and disorientation since 2 days, and reduced verbal output since 1 day. On examination, vitals stable, she was afebrile and mild pallor was there. System examination, RS and CVS was normal. Patient was drowsy with subtle weakness of the right lower limb. Her initial investigation showed a striking thrombocytopenia with a platelet count of 1000, which gradually improved over her course of treatment. Her sodium was 115 and her INR was 1.79 as she was taking warfarin, and APTT was 51.3. Rest of the investigation were normal. Peripheral smear showed normocytic normochromic anemia with occasional spherocytes and severe thrombocytopenia. Since she presented with headache and disorientation, a CT brain was done, which shows an acute on chronic STH noted in the left frontotemporoparietal convexity with a midline shift of 4.5 mm. So, our initial impression was severe thrombocytopenia in a patient with background hypercoagulable state, which lead to complications such as STH. Differential diagnosis we considered were APS with secondary ITP and systemic lupus erythematosus. So to rule out this differential diagnosis, we have done some specific investigation, which include ANA immunofluorescence, which was 2+, that is nuclear granular pattern. ANA profile was negative. APLA workup was done, which shows anticardiolipin antibody IgM and beta-2 glycoprotein IgM positivity. Her complement level C3 was low, that is 60.4, and C4 was normal. So we came into a final diagnosis of APS with secondary ITP. Systemic lupus erythematosus was ruled out as she have no other complaints associated with systemic lupus erythematosus and her ANA profile was negative.
We couldn't think of any other probable diagnosis because she's been on warfarin since I think some 5 to 6 years prior to the presentation at medical rest. She had a pulmonary embolism, was diagnosed with APLA and was on warfarin since then. And now she is present with the severe thrombocytopenia and an intracranial bleed. So the other close DD was an SLE, but the ANA profile came negative. She had absolutely no arthritis, serositis, nothing to suggest an underlying other connective tissue disease. Is there any other DD that anybody would like to comment on? Any differential diagnosis other than this? We did not do a bone marrow because there was nothing abnormal on the peripheral smear, and we started her on steroid pulse from the very first day because the platelet count was just 1000, and then it actually showed improvement over the next few days, and the platelet counts picked up on discharge. So that kind of confirmed. We were almost sure that the diagnosis is secondary ITP. APLA is associated with thrombocytopenia, but it's generally mild to moderate, and severe thrombocytopenia is rare, very, very rare.
So she was managed with platelet transfusion, antiepileptics and anti-edema measures. Steroid pulse therapy was started with methylprednisolone 1 gram, and then it was tapered and oral Vislon was added. Warfarin was withheld in view of STH and restarted later on follow-up. Now the patient is on regular follow-up and warfarin and single antiplatelet. Now about the second case, it is a 45-year-old female. She is a known case of seizure disorder. She have history of antiphospholipid syndrome detected in 2012 after her first stroke. She was only 34-year-old at the time of stroke, and young stroke workup was done. As a part of young stroke workup, APS profile was done and was positive. She was on warfarin and single antiplatelet since then. In 2021, she had another stroke, and she also gave history of 2 first trimester abortion in the past. Systemic hypertension, dyslipidemia and hypothyroidism. She presented with complaints of recurrent episodes of documented hypoglycemia and altered behavior. On examination, her vitals stable, CVS, NAD, RS normal, CNS shows residual weakness present in the left side. Her blood investigation shows HB of 9.9, moderate thrombocytopenia with a platelet count of 63,000. Her APTT was 44.2. Rest of the investigations were normal. Peripheral smear showed microcytic hypochromic anemia with moderate thrombocytopenia and mild leukopenia. Here also we have done APLA workup where beta-2 glycoprotein IgG was positive and cardiolipin antibody IgG was borderline positive. As a part of hypoglycemia workup, 72-hour fasting test was done, and at 6th hour she had hypoglycemia with a GRBS of 14. At that time, insulin and C-peptide were sent. Both were found to be normal. Therefore, we have considered a differential diagnosis of insulinoma in her. Bone marrow showed increase in megakaryocytes, and previous APLA profile was positive in 2012 done elsewhere. So therefore, to rule out insulinoma, we have done a CCT abdomen that didn't reveal any mass lesion, and there was no evidence of pancreatic neoplasm. So she was discharged, and follow-up a PET scan was planned, which shows an abnormal increased DOTA-TOC uptake in the neck and primal body of the pancreas, impression insulinoma. So here our final diagnosis was insulinoma with underlying APLA syndrome.
Here again, we searched the literature for any possible association between an underlying APLA syndrome and a neuroendocrine tumor, but we couldn't find any. Associations like lung cancer, I think ovarian cancer are there, but otherwise insulinoma per se, neuroendocrine tumor in an APLA, I couldn't find anything in literature. Probably these are just two diseases in the same patient. So the CT did not pick up any neoplasm in the pancreas, so we had to do a PET scan, we had to do a nuclear scan, and that is when we found that there is a insulinoma in the pancreas.
So she was readmitted for the resection of the tumor and underwent laparoscopic central pancreatectomy under GA on 17th January 2023. Pre and post procedure LMWH was given as there was high risk of developing catastrophic APS. Post procedure patient developed AKI with severe thrombocytopenia, and she was initiated on high dose steroids, HT and plasmapheresis on alternate days, and anticoagulation with fondaparinux 2.5 gram in order to avoid heparin induced thrombocytopenia, and IV antibiotics meropenem and teicoplanin is being given.
To do a surgery on an APS patient is always risky because there's a high risk of the patient going into a catastrophic APLA syndrome, which is life-threatening. So we admitted this patient and we had administered her therapeutic anticoagulation both pre and post-surgery. Irrespective of all that, she went into acute kidney injury, APLA nephropathy, and she went into recurrent episodes of pulmonary edema. Finally, he had to take her for HD. We started her on high-dose steroids, methylprednisolone, and plasmapheresis. We had to, initially she was on low molecular weight heparin, but then later the platelet count started dropping. We were really not sure whether it's a part of the patient going into a catastrophic APLA or whether it's a part of a heparin-induced thrombocytopenia. To send a PF4 levels and to wait for, it takes at least a week to come. So we changed over to fondaparinux. And we continued the patient on that since then. We had to give her a few platelet transfusions when the platelet count dropped to around 10,000 and there was bleeding from the drainage site. The sad part is she went into sepsis after that with a procal more than 100. The counts even climbed to 1 lakh, kind of a leukemia reaction. Now she is on antibiotics, initially meropenem, teicoplanin, and then now she is on tigecycline. And the latest blood cultures is ground GNB. So this up and down, it's just happening. She's going into sepsis. Initially started off with plasmapheresis. She got immunosuppressed. She's again gone into sepsis. Now she's still in the ICU. She's still in our hospital, currently in the hospital, and on intermittent HD and steroids. But now the high dose steroids have been stopped. She's on 1 mg per kg prednisolone, and on high-end antibiotics.
Now third case. It is a 43-year-old female. She's a non-case of type 2 diabetes, systemic hypertension, OAD, post-COVID state, anemia with history of blood transfusion 3 years back. Presented with complaints of abdominal pain and vomiting for 2 days, complaints of headache, protrusion of right eye, and occasional diplopia for 1 day. She also gave history of fever 1 week back. On examination, she had tachycardia with a rate of 113, BP was 140/80, she was febrile, tachypneic with a rate of 28, and saturation was 89 and room air. CVS was normal, RS bilateral air entry was equal, per abdomen distended with left hypochondrial tenderness, right eye proptosis was seen, and subconjunctival hemorrhage was present. Her blood investigation showed severe anemia with an HB of 66.2. Total count was 24,000, but procal was negative and CRP was 85. Her platelet count was 54,000 and APTT was 38.9. Her peripheral smear showed microcytic hypochromic anemia with neutrophilic leukocytosis and thrombocytopenia. Rest of the investigation were normal. In order to get a diagnosis, we have done multiple imaging study for her. CT chest done shows multiple filling defects in the pulmonary artery suggestive of pulmonary thromboembolism. CT abdomen showed splenic infarct with splenic artery and vein thrombosis. MRI brain done shows venous infarct with hemorrhage in the left temporal lobe. CT cerebral angiogram was done which showed dural venous sinus thrombosis extending to jugular bulb and internal jugular vein. Lower limb venous Doppler was done, shows bilateral great saphenous vein thrombosis with small eccentric thrombus extending to right common femoral vein. Therefore, she had multiple sites of thrombosis, that is cerebral venous thrombosis, pulmonary embolism, splenic artery thrombosis with splenic infarct, splenic vein thrombosis, and deep vein thrombosis of the lower limb.
So I would like to have a small discussion. Any possible DDs? This is how the patient presented with multiple thrombotic events from the head down to the leg. A sudden onset. She presented with severe abdominal pain. She was initially under gastroenterology and then we took over because after it was extensive thrombosis. Any guesses, any differential diagnosis? Yeah, that's the first thing that we considered. Anything else?
Was it demonstrated in the MRI?
No, sir, it is not. Any other DDs? Shall I proceed?
So differential diagnosis we considered were catastrophic APS syndrome, post-COVID state, underlying occult malignancy with hypercoagulable state, paroxysmal nocturnal hemoglobinuria. Based on this differential diagnosis, specific investigation was done where APLA profile shows cardiolipin antibody IgM positive and beta-2 glycoprotein IgM positive. PNCA, CNCA was negative, COVID IgG was negative, ANA immunofluorescence, ANA profile was negative, Ham's test and bone marrow were negative.
Ham's test was done for PNH. The ideal test is flow cytometry for CD55-59. It's very expensive, and then since we got a positive APL profile, we did not go forward with it. We did a bone marrow to rule out if there is an occult malignancy. Plus, we have already completed a CT test that pretty much ruled out it did not pick up any lymph nodes or any malignancy as such. Post-COVID, COVID IgG was negative, but she did give us a history of COVID in March. I think that was a few months prior to this episode. Yeah, that were the probable DDs, and then we excluded one by one, and then finally, since APS was positive, we came across, our final diagnosis was a catastrophic APS.
So, catastrophic APS, since as there is multiple organ system involvement and time span of the progression is less than 1 week and APS positivity was seen. Management, steroid pulse therapy was started. We considered plasmapheresis and IVIG in view of catastrophic APS, but she showed good response to steroid. Therefore, it was continued. Therapeutic anticoagulation was given with heparin, which was later changed to warfarin on discharge, and empirical antibiotics were given in view of elevated total counts. Now about the antiphospholipid antibody syndrome. It is defined by the occurrence of venous and arterial thrombosis, often multiple and recurrent fetal losses, frequently accompanied by a moderate thrombocytopenia in the presence of antiphospholipid antibodies. which are lupus anticoagulant, anti-cardiolipid antibody, anti-beta-2 glycoprotein antibody. Now about the criteria, it is Sydney revision of Sapporo criteria. Definite APS is set when there is one clinical criteria plus one laboratory criteria. Clinical criteria involve vascular thrombosis, that is arterial or venous, pregnancy morbidity, that is one or more death of normal fetus more than 10 weeks, one or more premature birth at less than 34 weeks due to severe preeclampsia or placental insufficiency, more than 3 consecutive abortion at less than 10 weeks with other causes being ruled out. Laboratory criteria is the positivity of these antibodies, and medium to high titer should be there and at least 2 weeks apart. Positive test should be repeated at least 12 weeks apart. This is the initial pathogenesis. Antiphospholipid antibodies are produced by the B cells, which binds with beta-2 glycoprotein in the endothelial cells, and as a result of it, there is activation of the inflammatory cells and endothelial cells. Neutrophil, there is neutrophilic extracellular trap, and it promotes the coagulation. As a result, clot is formed. The interference with trophoblasts and decidual cells lead to obstructing morbidity. The pro-inflammatory and pro-thrombotic changes induced by antiphospholipid antibodies are listed. Now about catastrophic APS. Discontinuation of anticoagulation, surgery or infection in a patient with APS leads to catastrophic APS. Evidence of involvement of 3 or more organs, system or tissue must be there, and development of manifestation simultaneously or less than a week, and confirmation is by histopathology of small vessel occlusion in at least one organ or tissue. Laboratory confirmation of the presence of antiphospholipid antibody. Now about the management. Definite APS with first venous thrombosis event, oral anticoagulation therapy should be given and target INR is between 2 to 3. Arterial thrombosis should receive oral anticoagulation with target INR between 3 to 4, or combined therapy with antiplatelet and anticoagulation with INR target between 2 to 3. Warfarin is a recommended drug of choice. Lifelong treatment with anticoagulant is essential to prevent recurrence. Mild to moderate thrombocytopenia is usual in APS and is not a contraindication for anticoagulation. Now management of catastrophic APS. Here we do triple therapy, that is anticoagulation with heparin, high-dose steroids, and plasma exchange or intravenous immunoglobulins. For patients with refractory APS, rituximab and eculizumab are good alternatives. Now prevention. For high-risk patients, those with SLE or persistent positive lupus anticoagulant, primary thromboprophylaxis with low-dose aspirin is recommended. Low-dose aspirin is administered from the beginning of pregnancy until just prior to delivery to prevent fetal loss. This may be combined with daily subcutaneous heparin in case of previous fetal losses. In case of ongoing anticoagulation and if she becomes pregnant, warfarin administration should be discontinued as soon as the pregnancy is diagnosed, since it is teratogenic, and should be switched to heparin. Thank you.
Sorry, sir. No, sir. Rivaroxaban, there are studies, but in persistent, in high-risk APS, if all the 3 are positive, or if it's lupus anticoagulant positive, the risk is quite high. They have a tendency to develop another thrombosis. So warfarin is still the safest alternative. Warfarin or azicomarin. I am not sure, sir, because I just referred yesterday, and then I had spoken to a rheumatologist also, because he is also there. So even he was of the same opinion. I don't know whether it's changed after that, so I'm not very sure. In high-risk APS, but I think in moderate risk, so if I'm talking about all the 3 positive or lupus anticoagulant positive. So if it's a low-risk APS, you may consider, but I think it's safer to go with warfarin. And the third case, we did repeat an IgM, anti-cardiolipin and beta-2 glycoprotein after I think a year or so. We are ideally supposed to repeat it after 12 weeks, and it came negative. So then she does not fit into a diagnosis of APS. It was mostly a transient APS. Really do not know the reason why, because many of these viral fevers, especially COVID, is known to trigger all this. but to present with such extensive thrombotic events, both arterial and venous, is very, very rare. Generally, many of these infections are followed by a cardiolipin positivity, but generally do not develop thrombosis.
Aspirin, right? Unless there's past history of thrombosis in
No.
pregnancy.
If it's a high risk, you better give aspirin. If there's a past history of thrombosis or miscarriage, I think it's safer to give a heparin also along.
In the absence of any such history, there's no need to, I suppose, because we don't routinely screen a patient for these antibodies.
Oh, that way, sir.
Yeah,
Okay. Okay. This is,
And secondly, the RA factor is positive in say 5% of the population. Similarly, these antibodies are also positive in roughly 5% of the population.
in the general public. Sir.
In the general
Yes.
population.
But most of them do not develop thrombotic events. Thank you.